Hello.
So we are going to start. The purpose of this meeting is to groom the youngsters to share our surgical skills. They are the future of ophthalmology. And we have some youngsters here. They are very young, and there are many, maybe thousands will be watching on YouTube, and it will be recorded and it will be there, and thousands or maybe lakhs of views will be there afterwards. So we are going to have a very quality meeting today. So let us start. I'll ask my brother Arup, Sir Purendra Bhasin sir, my friend Navneet, to please light the lamp and inaugurate this meeting. And please, Manush, please come. Dr. Das, Pradeep Das, please come. And after this, we are going to start live surgery. Before that, we will have only two talks, on from Purendra Bhasin sir and on from Navneet, my friend. And after that, Dr. Arup will be doing surgery. Dr. Manush Nath, please come. Please hold my hand. Thank you. Yeah. Is it ready? So we are going to start. Yes. Is that?
Thank you.
So now I'll request Purendra Bhasin sir to give his talk, and after that Dr. Navneet, and then we will start surgery. Yes, yes. Yes. Dr. Manush, please come here. Manush, you also please come here. প্রসেনজিৎ এই লাইটটাকে এবার এই দিকে সরিয়ে দাও, খুব ভারী আছে। শোনো প্রসেনজিৎ আর যেন অ্যানাউন্স না করে এইভাবে, যে মেসেজ পাঠিয়ে বা ফোনে বলবে, হ্যাঁ, অ্যানাউন্স যেন না করে, নকাকু যেন অ্যানাউন্স না করে, এখানে ডিস্টার্ব হয়ে যাবে।
A bit long presentation because I will be speaking, as has been asked by Dr. Pradeep, to tell us about transformation from routine monofocal lenses to the newer generation lenses, how to transform and what are the advantage and what are the cases which we should select for. Although most of us are aware of it and most of us must be doing it, so all these newer lenses which are available, like extended depth of focus lenses and trifocal, multifocal IOLs. So these are the new things, but we have to be very, very careful, because when the package goes high, so patients' expectations also rise enormously. They also go very high, and it becomes very difficult to convince. So always under promise. If you give better, it's good. But if you under promise and deliver better, then the patient will be happy, more satisfied. Otherwise, the same thing. If you are doing good, you have done a wonderful job, everything is fine. The patient is having 0.5 cylindrical, which was there before also, and your surgery has been non-astigmatic inducing surgery. Astigmatism 0 was induced because of your perfect incision, wound size, perfectly placed lens and all. But for that also patient is going to complain to us. So this is very, very important, the patient selection and the patients with the comorbidities, whether which lens should be suggested to them, what kind of surgery we have to plan for them. All these things are there. And many people, they say that glaucoma is a contraindication, or we should be very selective in doing in glaucoma patients the multifocal or trifocal lenses. But in my personal experience, if the field effects are limited, if the glaucoma is not advanced, if the patient is religiously following the medicines and using it, and the things are under control, then we can do in such cases multifocal lenses also, if the field effects are not very high, cupping is not too much, and so all these things are there. And other thing is, in maculopathy cases, you should be very, very cautious in doing a multifocal or trifocal lenses, because they are the cases which are highly unsatisfied by the multifocal IOL, because macular pathology, and in advanced cases, many of us have seen that the patient gives the history of hemiparalysis or RTA. So all these things should also be kept in mind. I have seen many cases who have got hemianiopic field defects. Patient is compromised with that. 10 years back he had a RTA. Patient is compromised. He is well adjusted to this scenario. Never seen. But when we saw we did the field defect 30-2, we found that there is a anopic field defect in both the eyes. So all these cases, because of the cortical trauma to the cortex and hematoma or whatever it may be. So in RTA cases, optic nerve cases, when the pallor is there, so you should be very, very selective in doing a multifocal IOLs. And in such a case, advanced monofocal lenses are superior. And some studies with VVT lenses are also saying that in such a condition we can do VVT lens, EDOF lenses also. I have also done in a few number of cases, but I don't have large number of experience with the large number of cases with these lenses, VVT lens especially. So advanced monofocal lens like IHANS, or in Indian counterpart Magnificent from and Appasamy also has come out with the advanced monofocal lens, and our care group Magnificent lens. So these are also quite good in the category of advanced monofocal. And some lenses are a mixture of multifocality and EDOF. So that lens is like I think one from Orolab, which has got central bump like VVT, as well as two rings are also there in that lens. So they are mixed. They say that it gives better near vision as compared to VVT, and near vision can be N6 or so. But we have to test on our patients, and other things also has to be taken into consideration. So that is what in nutshell I wanted to convey before, it's done. Any question from anyone? And we can do it from directly.
2828 দয়া করে গাড়িটি সরিয়ে দেবেন অনুগ্রহ করে শুনবেন একটি গাড়ি সরাতে হবে
इसको
फोर व्हीलर
कर दो
নাম্বার 2828 দয়া করে গাড়িটি সরিয়ে দেবেন
I think we can stop this announcement. कौन सा? This. नहीं कोलकाता था ना हाँ newer aisles.
Just 1 minute, sir. We have with us Dr. Manav Pal. Usually happens whoever comes here, we give him a bouquet, and he has come all the way from Narendrapur with a bouquet for me.
Wonderful.
Come, sir. Please come. Thank you, sir. Thank you very much. He's a great ophthalmologist, and when I was in Shankanachalaya, he came with a patient. The patient was having some problem, and to help the patient, he was with the patient.
Very nice.
Thank you, sir.
Thank you. That is the sincerity which is required. Thank you, Dr. Pradeep, for giving me this opportunity to speak in front of the August gathering here. And I really see a beautiful practice you have arranged over here and developed this beautiful setup in this remote area of the country. I appreciate your gesture, and last night I had an opportunity to stay with him in his farmhouse, and we had a good time and a nice breeze, good weather. Morning we had a wonderful time. We had a good cup of tea in the natural good wind and good breeze also. And thank you, Dr. Pradeep. And good morning, everybody. Transformation from monofocal to next generation EDOF IOL or next generation IOL. So vision correction technologies have grown, and we all know the lenses now have quantitative and qualitative the properties in them, unlike multifocal lenses which used to give us a qualitative, but quantity was not good. So extended depth of focus is a combination of both quantity and quality. There is a drastic change in lifestyle, which because the patients are now elderly age group, and they require early surgery at early age and early cataract, both. So now we see patients who are 50 years, early cataract, simple posterior subcapsular, early nuclear changes, and with eye trace we can see the DLI also of the eye. So whether the defective lens index is there, mild polyopia, they will go for surgery. They want surgery, and sometimes we have to go for a clear lens extraction also. Elderly patients are now having active lifestyles like driving, smartphone, laptops, etc. And at the same time, technologically and surgically, our doctors have improved and machines have also become better. And therefore, that's the reason patients' expectations have gone very high, and they want a spectacle-free vision with quality from the cataract surgery. And these are the various distances and the various gadgets patients will require for the reading. As you can see, they use textbooks, they use a laptop, they use tablet at the distance of 40 to 60 centimeter, and then at the same time they have to drive and use the dashboard, which is very, very common, which is at 60 to 80 centimeter away. So various modifications in the past have been made, we all know, and I will not go into much detail. So various diffractive lenses with various additions, less addition, 2.5, 3 diopters, 3.5 diopters, 4 diopters, apodization, many things have been tried to decrease the glare and halo, which is commonly associated with the multifocal lenses. So trifocal lenses have also come, and it incorporates multiple focal points, thus provides patients with clear vision at multiple distances like near, intermediate and distance. Need for additional corrective eye wear such as reading glasses or bifocal is minimized. And studies have shown high levels of patient satisfaction with trifocal IOL, because now many a times we have seen the patients who are officer grade or who are tall enough. So when they were working on the table, they had to go close to the laptop, to the desktop screen, or to the paper, or they have to bring close to those files close to the eyes, and then they have to see, because near point was very close. So intermediate trifocal lenses are definitely a better option in such a cases. And in what kind of patients we should go? Who have a strong desire to be spectacle independent, when there is a occupational requirement like sportsman, artist, reader, etc. And I will strongly recommend for housewives or retired elderly persons who do not drive, or they don't drive at night. I specifically ask, even if they drive in daytime, I specifically ask them whether they drive at night, how common it is for them to drive at night. Because glare and halo, starburst, they are common when the light from opposite side is there, or when they are seeing at a bright light at a distance. So
if they have driver, then there is no problem.
Then there is no problem. If they have a driver. And I strongly recommend, in cases elderly patients who are wheelchair based, or who are immobile due to any reason, who have dementia, who have Parkinsonism, who are bedridden or mentally inactive. Because if they have to see at near, or if they have to eat, if they have to look at the thali, the plate, so they should be able to see near things also clearly. Otherwise, they will find that there is something, whether this is an insect in the meal or in the dal, or whether it is tadka in the dal. So they have to, because this is the common thing which they tell us. So in such patient, I specifically ask their attendants, better you go for a multifocal lenses. This is from my experience. I have gathered this thing, and whether you go for Indian lenses are also equally good. I don't have any financial interest. Patients with hypercritical demands and expectations should be avoided. Patients requiring to drive vehicles for long hours, especially at night, should be discouraged for multifocal IOLs. Patients with ocular comorbidities like macular pathologies, I said earlier, corneal dystrophies, advanced dry eye, advanced glaucomatous changes should be discouraged. Now, the limitation with this presbyopia correcting multifocal trifocal IOL is that the problem is with the photopsia, dysphotopsias, or dissatisfaction to visual disturbances. That is the most common. As you can see, 78% of the patient, they say that this is the issue, and which they don't like. Day before yesterday only, I have a patient, I implanted synergy lens. He is of age of 52 or so, and he complained that I am having this problem, and he also had some dry eye. So he was not very happy, because the contrast sensitivity decreases with the trifocal or multifocal lenses, whatever you do, and the glare and halo with the night driving. So if they have to go for wedding somewhere or some party in the evening, and they have to return at night, then it becomes difficult for them to drive. So that was the reason. So I have suggested to go for EDOF lens in the other eye for the same patient, to decrease the issues. Need is a presbyopia correcting IOL without visual disturbances. So unmet need with the presbyopia correcting IOL is we should have a reduced halos and glare, monofocal mesopic contrast sensitivity, as I said earlier, and ability to perform functional activities at near, intermediate and distance, at least for intermediate distance, and if possible, complete spectacle independence, which is what is expected by these patients. So this EDOF, or extended depth of focus lenses, they help in presbyopia correction and provides a usable near vision for day-to-day purposes, and they do not render the patient a glass-free near vision. That should be explained to the patient. But it assists to get freedom from near glasses for most of the near activities. So various types of such lenses are available in the market. One is with by manipulating the spherical abrasions with annular zones of positive and negative alternate spherical abrasion in the IOL to increase the depth of focus, like our aspheric eye-hands lens from J&J. No financial interest. Challenges are the variability in the existing spherical abrasion in each eye. So that is the reason why not all patients, they say the same results are available with this lens. Eye-hands lens, all patients are not 100% satisfied, because the previous spherical abrasions which the eye is having, that we are not taking into consideration. So that can negate and reduce the quality of vision. So then another category comes with the use of diffractive elements to produce the EDOF effect. Advantage, so there are 2 or 3 maximum rings which are present, diffractive elements, and our central optic zone is larger, so it is almost 3.5 to 4 millimeter size. So advantage of such an IOL relative to diffractive multifocal IOL have been questioned, because definitely they will also produce some amount of glare and halo, and use of a limiting aperture to extend the depth of focus. So challenges is that the amount of light entering the eye may be significantly reduced and their quality of vision may not be as good. So pinhole effect, what they say. So pinhole kind of a vision they provide, they use it. So variety of lenses available in the world are pure EDOF IOLs, like, and the first one was the SIFI Minivel Ready, but this is a not a hydrophobic acrylic, this is a hydrophilic acrylic. The Technics eye-hands and EDOF IOLs utilizing the pinhole effect. So the IC8, which was for some time available in the country, extra focus pinhole implant, but it has not gained popularity. Then comes the hybrid IOL with the spherical aberration modulation, modification, at the same time some diffractive rings, like Lentis M+, which is very, very popular in our country now. But again, this is a hydrophilic acrylic lens. So, and various other things have been incorporated, like in Technics Synergy also they say that is a combination of a trifocal lens and a eye-hands lens. So spherical aberrations modification has also been done alternately along with the rings in this. So variety of lenses are available. Coming to the VVT IOL, this is a lens which has got a bump or a slight elevation which is of the size of 2 millimeter in the center, as you can see there. So this is a X-wave technology. It consists of 2 smooth surface transition elements that simultaneously stretch and shift the wavefront, and this creates a continuous extended focal range. So this slightly elevated smooth plateau of 1 micron, this in the center, this stretches the wavefront, creating a continuous extended focal range, and the small curvature change across the 2 millimeter region in the periphery. This shifts the wavefront from the front to the behind. So this will increase the area of where we can have the intermediate vision, as you can see here in the bottom. This is a monofocal lens. This is the graph, and this surface a slightly elevated smooth plateau that stretches the wavefront, resulting in extended focal range. So this extension of the focal range is there, but this is behind. So it has to be brought in front to focus on the retina. So this is done by the second element of changing the small curvature in the lens, in the center part of the lens. So glare comparison is as good as the Acrisoft IQ VVT lens and IQ lens. On the left side you can see the glare is more or less same, and this is with the Symphony Technics Symphony, which was the lens of bifocal type, and the Zeiss 80 layer lens, or which is again a multifocal lens. So this provides a superior, intermediate and near while maintaining distance vision comparable to Acrisoft IOL. So this is a study which concludes that the VVT IOL provides patients with good distance and intermediate vision and functional near vision. Functional near vision is that if you increase the illumination or you increase the distance, you may get it. And with low reported bothersome halos and glares and starburst. And another study which was published in 2022, initial results of visual function after VVT implantation in patients with ocular pathologies are encouraging, as we were discussing just now, with high patient satisfaction and few difficulties for daily activities. Another study which is published in 2021, that conclusion is that is a well-tolerated choice to correct for far and intermediate vision. Spectacles are needed to optimize near vision. Our data strongly suggest dynamic pupillometry as a useful investigation to optimize post-operative refractive success. This study, which we got published in this year only, of 64 patients in 64 eyes in 64 patients. So our results say that among the total study population, 82.5% were male, and the most common age group was 41 to 50. In addition, 93.6% had a distance visual acuity of 6/9 or better, and 93.7% had an intermediate vision of N18 or better, whereas 50% had a near vision of N18 or better. All the patients had good contrast sensitivity. OT is ready? Yeah. Good contrast sensitivity, and in 79.4 and 95.2% of study subjects were comfortable with distance vision, whereas 74.6% were comfortable with intermediate and near vision. So this was it, the study which we published in IGO. So this is how the surgery is, and capsular axis of 5 to 5.2 millimeter size, and guided by the Varion is done. And I am an old time person, so I use cystitome or 26 gauge needle to do my capsular axis. And I start from the area from where I am doing the temporal side. If I am doing from the main wound, hydrodissection is there, a fluid wave you can see. And so the phaco is done in a routine way, 4 quadrant, soft cataract. Okay. So this is the lens, you can see, and I use some viscoelastic to distend the bag, and then hydro implantation of the lens is done with the IA, irrigation handpiece. And then this step is very, very important. You have to match the Purkinje images of the microscope with the centration of the with the center of the lens. Otherwise, the patient will not get, like in all multifocal lenses, we coincide the Purkinje images. We have to do in these cases also. And toric lens. Coming to IHENS lens, this is again a good lens. It is based on refractive technology. No rings are there, and based on a continuous higher order aspheric surfaces, and some base geometry as all other Technis one-piece lenses, and reduced spherical aberrations to nearly zero. So they also give the intermediate vision, and if we do micro-mono vision in these cases, so patients can always be happy if we do micro-mono vision surgery and adopt that in both the eyes. So patients will be happy and for the day-to-day activities. Don't tell them that there is a good quality of near vision will be there. Never tell them, these patients. And it is equally tolerant to decentration as compared to our VVT, because it's not we don't have to match it with the centration. So in this particular case, the near ad, you can see the patient was done in 2021, both eyes were done, and patients both eyes are 6/6, and near addition is only 1.5 as compared to 2.5 or 2.75 we are giving in other cases. So this shows that definitely the patients are happy. So CRV lens is the synergy lens, and this is again a trifocal lens. It is a very good lens, compared to panoptics, the continuous range of vision is there, as you can see in the red graph. So, the glare halo is less, and patients will get good distance, intermediate, and near vision. The pearls for best surgical outcome and happier patients are a detailed ocular examination to rule out any vision affecting comorbidities, understanding the patient need and expectation, explain well about the pitfalls and reasonable expectations from the surgery, always promise less, deliver more. IOL power calculation is very, very important, should be very accurate, and we should check it several times. Last night only we were discussing, I check almost 3 to 4 times the IOL power and the keratometry in all these patients, because sometimes due to dry eye, dryness, or many other reasons, patients' IOL power calculation is not perfect. So key takeaway pearls are: plan pure EDOF IOL for any monofocal lens patient, like uncontrolled diabetics, very active lifestyles, ocular nerve, and macular pathologies or corneal pathologies. So pure EDOF lenses or advanced monofocal lenses are suggested. Plan multifocal, trifocal for housewives, non-driving lifestyle with no other ocular pathology. Select an IOL which has stable toric correction possibility, and small amount of astigmatism should be corrected for better outcome. Now I correct even 0.75 diopter of astigmatism, because I have seen these patients are highly satisfied if your astigmatism is all. So I prefer doing toric VVT or toric trifocal or multifocal lenses, and an immaculate surgery like you all are doing with 360-degree overlap is very, very important. And in case when there is a primary PCR, don't promise them. Like in posterior polar cataracts, don't promise premium lenses. You tell them if the surgery will allow, your eye will allow, then only we will do. Otherwise, do not promise them to do or assure them that we will be able to do in such cases. A well-centered, aligned IOL at the end of the surgery is very much required, and we should not hesitate to do laser touch-ups for refractive lens. Thank you. Such kind of surgeries should be avoided, as you have seen when the lens there is some vitreous peaking of the pupil is there, and IOL is partly in the bag in another case and partly out of bag. So, and trifocal lens has been implanted, premium lens has been implanted. So such patients can never be happy. So please avoid such things. Patient satisfaction. To conclude, I have already said, I think we should watch the surgery now. Anything else we will discuss during the break in between. Thank you.
Thank you, sir. Thank you. Great presentation. Please be with us. Arup, are you ready?
Yeah, yes, good morning.
Good morning.
Just I take a little bit time to adjust the microscope. So good morning. Thank you, Netrajyoti. Thank you, Orita, for giving me the opportunity. This is unfortunately my scheduled patient, which is supposed to implant Clarion toric. The patient was ill and he not admitted. So I selected one case. This is a monofocal lens and the cylinder is a 0.6, 0.7. So it is not advisable 0.6, it is advisable for toric lens. The patient is a grade 3 cataract and I am using Lumera microscope today, and Centurion machine, balance tip. This is my usual machine I used to operate every day. And this is a case, unfortunately, the Afghan people do not bring the D cartridge. So I prefer to going for this 2.8 incision. You know, if you don't maintain the 2.2 D cartridge, then it is no point to use the 2. Again to give the 2.2 incision and increase this. My incision size always a 15 degree in cases of left eye, and my calculation in all my toric patient as 15 degree in left eye, because it gives me the advantage my hand position. That is a single planar incision, and the most of the surgeon actually nowadays shifted to the single planar incision. I don't think very few surgeons so far still using the 3-plane, but the most of the surgeon goes for the single planar incision. The advantage of the single planar incision is the foreign body sensation is slightly less in probably in the post-operative period, as because of this liquid lens shagging, incision shagging. This is a 1 millimeter side port. I use always MDR. Couple of years I shifted to MDR, and I use Rexis. And the most of the cases today's my in cataract volume 60% is actually toric. So I do the most of the cases do the Callisto guided Rexis. Almost all the 60% cases, and whenever I feel this patient is very important, like trifocal, I do Callisto guided. So as I using the Callisto guided day by day, my Rexis size improve. It is always almost I try to fix it in 4.8 to 5 millimeter. Not more than that, so that I can capture there is a optic overlap, Rexis overlap over that optic. It's better to remove a little bit of visco before going for the hydrodissection. And as a hydrodissection is the fluid wave, hydrodissection is complete. Now coming to the chopper, as I prefer to go for always vertical choppings, I use slightly long shaped vertical chopper. Can I handle this scope? Look at the light. So before going for this machine, is I used to do. Can I have the 70?
Hello, Arup, do you do spin before entering the phaco probe, or you thought that every case will rotate?
No, I'm not. Manada, can you please repeat your question?
No, no.
You are not audible.
No, actually, what I am asking you that after hydrodissection, do you do spin in all cases, or you don't do spin at all? Rotation.
Yes. If you are very novice, it's better to do rotation. But here I saw there's a clear hydrodissection, so I don't rotate.
Yeah. But what is your advice to the juniors? Because
for the juniors, it always
yes. So
always rotation,
yes,
single-handed
yeah,
or by handed,
yes,
just rotate.
yes. So no spin, no win.
Yes.
Dr. Uday Devgan always says no spin, no win.
This is our standard other machine is it's a 70 IOP. That's when bottle height is almost 110, 95. Okay, 95. So, but this machine has IOP control. Go for the 50 IOP. You can see this. The water is coming very less. Go for the 20. See, water is so less, and maintain the 20 IOP. So I prefer to go for the 20 or 30. So can go for the 30. Yes. So I prefer go for the little bit debulking in the central part. prefer to go for now chopping. If you slightly develop the cases, then it is easy to chop. And if you want, you can chop the nucleus n number. And so
Actually, Arup, actually these cases are sweet spot cases.
Yes.
But actual challenge is when very soft cataract chopping is very
soft
severe.
cataract is
So
a
these are
problem.
very sweet spots. So actually these are cases ideal for the juniors. Ideal for the juniors.
soft cataract is to go for the stop and chop.
Yes, yes.
It's better go for the stop and chop.
Yes. Actually, when juniors they start phaco, usually they should select this type of cases.
Yes, they should start.
Yes, definitely.
Now my chopping is complete. I prefer go for what it keep
Sir,
to keep your phacoprobe in the central position and manipulate the quadrant in the left hand.
how many chops do you prefer, sir? How many pies?
Yes, here is almost 10-12 pies, but it is not always possible to create 10-12 pies in every case. So as Manoj rightly said, in the softer cataract, the idea is to reduce the energy level, CDE. So I don't know what CDE, I will calculate it later. Go for just central, keep your phacoprobe in the central. And this machine has a beautiful, yes.
So for the,
Now you can see this cortex, you can remove the cortex.
and sir, for the, juniors, do you recommend them to take out the sharp chopper?
Yes, for the junior, you can remove the sharp chopper. And now this machine is absolutely controlled. And I am using this machine almost, I don't know, 10 years, more than that. I can remove all the cortex with this phacoprobe itself. This is my regular phenomena. But it is not advisable for the junior. And after that, I did the posterior capsule.
So Rex's size looks excellent, sir. It's like femto created.
See, I always prefer to this size. After doing the Callisto guided, and my Rex's size is improved a lot. Now I go for
See,
the
actually, Disha, we have Callisto.
Anti-capsule polish, you go for anti-capsule polish or not, it's your choice. But definitely you should try to remove all the fiber.
Actually, Disha, we have Callisto Virion, but what is your advice for the juniors? How they can do such type of exercise?
Also very good.
So give your tip.
Rex's marker. Try to follow the Rex's marker.
Yes.
Rex's marker, try to use the Rex's marker. Otherwise, if you want to central, just always follow the parking image, not the pupil size. The pupil size, actually, this is a limbus to limbus, white to white is different in each cases. So, if you follow the limbus to limbus or the pupil size, then it's.
Have you used Rexis Sportsig using marker?
Yeah.
So some surgeon use, they're going to use all cases. So that is one way also. I have not used, but definitely that will also improve their accuracy and center.
This is a Clarion lens. This is the best lens in the Alcon basket, because there is a lot of this is a water content of the Clarion rays is much more than the IQ one, and they don't have the shooter today. So I generally prefer implant under under hydro. So, but here it is not available, but it is a very good injector, shooter one. You can see this, the Rexis is absolutely perfect, 5.5 millimeter. No, this is a 4.9 millimeter. 4.9 to 4.8 millimeter.
Just one question, Arup.
Yes.
Myself, Parvez.
Yes.
You prefer under irrigation, but why you are implanting this with Visco in this case?
Yes, because shooter is not available. Shooter injector not available here.
Okay, okay. If the shooter is,
Yes,
then would have preferred the irrigation, under irrigation.
Yes.
Okay, okay, okay. Very nice surgery.
And
Nice demonstration.
I'll go just slightly behind the lens because for if you implant toric oil, it's better to remove all the viscoelastic. And after this, I always prefer to keep my haptic inferonasal, inferatemporal and superior nasal. And you know, this is the study, the retrospective study by Bonnie Anderson that shows that this position of the lens haptic have the least incidence of negative dysphotosia. So I always prefer, until unless it is a toric lens, I always keep my haptic in this infernasal and temporal. And now come to the hydro. It's a very important to hydration of the wound. Be careful, your wound should not be leaked in the post-operative period. The chances of, if you careful about this step, and your definitely you will secure the case. I generally don't hydrate the main port, but if here it is a slightly, I think 2.8. Sometimes I hydrate the lens, and don't overinflate in case of what is this? Okay. So I put little bit of Vigamox 0.1 ml. I keep my Vigamox in the insulin syringe, and the end of the OT I always. And now during the removal of the speculum, it is always important. Do not press the eyeball. Just leave the speculum, rotate it, and remove this. Thank you so much. It's a wonderful setup.
Thank you, sir. The excellent surgery. Nice tips for the juniors as well.
Do you have any question regarding?
Please repeat the positioning of the IOL once more. What is the benefit and how this negative dysphotosia?
See, this is how it is works. If you see, these are the chances of negative dysphotosia. Actually, it is a peripheral scotoma in the retina, and some light goes over the lens and behind the lens, and the edge there is a absolutely reflection and create some kind of scotoma in the periphery. So, which position actually benefits, but it is retrospectively seen that if you keep your haptic inferotemporal and superior nasal, that's when means if you keep your haptic position in inferotemporal, the chances of negative dysphosia of the lens. This is not a prospective study at all. This is a retrospective study. The Bonnie Anderson studied all the patients, almost I forgot the number of cases, but what is observed that this position of the IOL keep the least amount of negative dysphotosia. This is published in JCRS probably 2017, 16 or 17.
Inferotemporal and superonasal position.
Exactly. If you keep the inferotemporal, other haptic will be the superior nasal. Superior nasal position is not important. The temporal field also important. Mainly, there is a inferotemporal.
Is there any study which says that the haptic should be placed completely 180 degree nasally and
See, that is
temporarily.
definitely that the second position, the less negative viscosity of shear, it is if your haptic is absolutely horizontal, 3-9 position, and this position even lesser create the negative viscosity of shear.
Correct.
But if you keep your haptic absolutely vertical, the chances of exposed edge will be the more. So chances of negative shear is much higher if you keep your haptic in vertical.
Congratulations, Arup, Dr. Toshniwal here.
Yes.
One of the two most important points which I saw is the size of the capsular axis, which you have demonstrated and traced, and that is very important for the young ophthalmologists also, because they are always confused. It should be small or it should be big. So that is the very good point. And second most important point which I noticed is after the hydrodissection, unnecessarily rotation, no need to do, because that may give the stress on zonules and all that. So that is the another very important message from you, that if you can see the wave nicely, so already hydro has been done. So unnecessarily doing this procedure, because these are the written in the books, but what to avoid and what to, this is what we have to listen from senior and experienced surgeon from you. Thank you, sir.
Okay, thank you so much.
But for beginners, it is always important to rotate, because they don't have that eye to see that whether the complete hydrodissection has been completed or not. So,
and then you saw is rotating, you're taking
correct.
out visco and more. So for the beginners, definitely
It should be a
rotation
must.
before entering the phacoprobe.
And even if we are not sure, we should do, the seniors also. Otherwise, the chances of other complications may be there.
It is more important for the soft type of cataracts. For hard cataracts, hypermeasured cataracts, you may not go for hydrodissections, but soft cataract, you have to rotate, I think, at least for the beginners, and or not.
So I am requesting Dr. Navneet to present his presentation. In the meantime, we can be ready in OT for the next case. So Dr. Navneet, please, you can start your presentation.
Can you send the computer person down?
Yes, sir.
Please. Can you give me that? Good morning, everyone. This is my fourth trip in Kolkata, this West Bengal, 3 for the conferences, and this is the first visit as to come to do the live surgery, to give some talks. I am very much thankful to Pradeep, who was my colleague at Shankar Netralaya in 1994. We were roommate. He was vitreoretinal, I was general ophthalmologist. And I was watching him. After the 5 o'clock, he was rushing, going this room, that room, medical record room, all the time sincere. Means we have to calm him down. But I am very happy to see I came yesterday 1 o'clock here, so I have watched his surgeries. I am enjoying his hospitality, as the Purendra has told, and his farmhouse, a fantastic staff. I was watching their, how they are giving instruments, how they are chit-chatting, everything. And such a small place, such a wonderful work, I must congratulate him. Senior sir, Das sir, Alam sir, very senior sir, Nath sir, Anamika, madam from Spain, and all respected colleagues. What we are showing today is very basic. Purendra sir has mentioned about the IOLs. Because I don't know apart from the basic. I am in the teaching since 2000. Almost 25 years I am teaching. Second important point, every day I sit with any doctor. He may be junior, he may be senior, for 1 hour for discussion. And that is the reason my mind has set for that, to watch, to see, to observe and to go. So many non-traditional things maybe I will show and I may talk. It may be correct or it may not be correct. But we will start with the very, very basic session today. When Pradeep has told me that most important as a teacher and as an analyzer and as a basic, what is the real thing in the phaco surgery is, apart from the machine, forget about machine, what I am using Alcon, I am using Johnson & Johnson. Here I am showing you, demonstrating some surgical media center, how this energy, vacuum, flow rate will work during surgery, and phacofluidics. Can I see this? So concentrate on these 3 parameters are important, because there is a lot of confusion all the time. Why I am showing you confidently that I have written 4 books in phacosurgery. My first book, 2013, is a simplified emulsification, where I have written all the steps, trench 20 pages, division 20 pages, like that. Then how to see the patient before surgery, then do's and don'ts in phaco. And last, in 2 years before, phaco machine and its application, where I have given the very simple definition. I have given the very simple definition of all these parameters. What is exactly vacuum, what is exactly flow rate. Everybody knows, but they should know completely, not in a halfway. दिख रहा है जा रहा है It is coming. Yes, it is now. Going, coming. No, it is going, coming. in our teaching, we are concentrating mainly the 4 steps. That is, first is the trench. For stop and chop, you should know the trench. For divide and conquer, you should know the trench. Trench is the most important step. Why it is important? Because all the phacosurgeries, we have seen the expertization that irrigation aspiration of the epinucleus is also by phacotip. But in our definition, what is phacosurgery? Phacosurgery deal with the nucleus only. Mainly, phacotip means for nucleus. So in trench, what is the significant point? And before on slit lamp we should see is the hardness of nucleus. And second is the size of nucleus. Every doctor when they come at our center, sir, what should be the length? What should be the depth? No need to ask. You should see your size of nucleus before surgery. If it is very hard, use more energy. If it is not very hard, use less energy. But length and depth depends on size of nucleus. This is the very important aspect in trench. So trench, one has to learn for, already I mentioned, stop and chop and divide and conquer. Second step is the division. In our practice, what we have seen, or when we have started the practice, suppose in 97, what is the difficulty was the division of the nucleus. Till it is division. Why the division is relatively difficult? Can anybody tell? Why the division is difficult? It is difficult step among all the 4 steps. Trench, division, hold and chop and removal of pieces. But specifically I mention here, why the division is difficult? Because there are different grades of cataract. Very soft cataract, difficult to divide. Very hard cataract, difficult to divide. Grade 2 to 3 cataract can able to divide. But still there is a difficulty. And why that difficulty is there during division? Can anybody tell? Anamika? Depth of trench. Okay. Any other thing? 1, 2, 3, 4, 5, you can tell anything and that is correct. Why there is a difficulty for trench or there is no difficulty for trench? Division, sorry.
That will depend on the hardness.
Perfect. Very hard cataract, difficult to divide.
4, 5, you just give energy and it is not going to be trained.
Correct.
One has to separate the pieces quite widely.
Correct.
Separation is sometimes is difficult to assess how much to separate.
Exactly. First,
One tip is there.
yes sir.
If you get the fundal globe, if that is visible, then the separation will be easy.
Correct. So you mean that good trench, ideal trench will divide the things better. After the ideal trench, still it is difficult. Why? Because if you notice, plane of incision and plane of working, exact working of the division is different. So when I go straightway, this is the plane of incision and here is the division. So when you go past the instrument like this and try to divide, first thing will happen, the leakage, pressure on incision. So we have noticed in our center at Navneet Hospital, we are not only recording these videos, we are recording videos as well as the external hand movements. When you go for division like this and you try to divide, you see all the instruments. When I ask on a first day, second day, third day, fourth day, according to the difficulty, if they will say, sir, I am getting difficulty for division, show me your movement. The movement will be, go, do like this. Go, do like this. We record those movements also. Then we, yes? Purendra is ready, sir?
Almost we are treating the patient.
Okay.
I will just.
Yeah, just one point and I will stop. So during the division, just give one tip to any doctor. Go with this. Instead of going and doing like this, just go do the wrist movement. So this plane will go to this plane, go with the wrist movement and then do. So the movement will be this. So these are the... Exactly. Correct. But go like this, pass deep and move like this. Exactly. So that plane will change and you will get the good division. So such a small tips, not only important for the beginners, it is important for the, yeah. Yes, yes. Yes.
Just to add on for the beginner, I have designed one GPS tracker many years back, just like Akaushi bridge of.
Yes.
It's just painted, and there is a plate. If you put a trench and you put your tracker inside the trench, you divide it.
That is what I am using in every case. Correct. Okay, Pradeep, I will stop here. And so the Purendra will start his case.
Yeah. Now, this is a case, male patient having glaucomatous changes in the optic nerve head, and he is having grade 2 cataract, other eye is pseudophakic. So IOL power, we are going to wash them. Can I have some viscoelastic? Yeah. So we will coat the cornea with viscoelastic and then 2.2. So I will be using a 2.2 blade.
So is the
Can you see the patient?
Yeah.
Reflex is there?
Yes, it's visible. Sir, is the surgeon under topical or block?
No, this is a block because Dr. Pradeep said that because of the language problem, the patient might not cooperate. So that was the reason.
Sir, do you recommend Trypan Blue in all cases for the beginners?
Yes.
So what is your advice?
Yes.
Even if it's a good glow, like this also?
Yeah.
Yeah.
Even if there is a good glow,
Yeah.
it's because sometimes when we start the capsular axis, the anterior cortical fibers and the nucleus, it becomes opaque. So it becomes difficult to complete.
Yes. So
now my incision I am giving. So I gave a direct incision. You can see. So I will go and to the 1.5 millimeter into the clear cornea and dip down. First I have to go uphill in the thickness of the cornea and sideward. Then I will create 2 side ports.
which company blade is this? You have used this?
Pardon me?
Which company blade you have used?
This was from Alcon.
Alcon. Okay, that's good.
And this side port also should be of 1 millimeter length. The tunnel length should be 1 millimeter. And I don't use forceps. I use these buds. If your incision is too much into the conjunctiva, then you will find that there is a ballooning of conjunctiva. So that should be avoided. Now we will put viscoelastic into the anterior chamber. Can I give you Trypan Blue?
But we must see that there should be a nicking of the blood vessels. So some little bleeding should be there. So that should be ideal. So your side port is ideal. It's just bleeding. That means in the limbus.
So I will put a Trypan Blue, and in the syringe itself I have put some air bubble.
Yeah.
and then the trypan glue will go inside. So it saves one step.
So,
And I don't wash this trypan glue.
so what is your contact time?
This much is enough.
Okay, but it's 1 to 2 minutes. Or 1 minute. A few seconds.
62. So I use 62. So eyeball is rolling up. So that's why we have to make it flatten. And viscoelastic should also be very, very optimum in the interior chamber. I pull the needle towards myself, and then I turn it. Some viscoelastic.
So for beginners, can we put viscoelastics over the cornea so that it will improve the visibility and
Absolutely.
little magnification also?
Right. Is it clearly visible there? Yes. Well said.
Yes, sir, yes.
So I will fold the flap on itself, and then I will rotate it. So,
Sir, I feel the focusing is not clear here. Probably you need to refocus the microscope a little bit. Clarity is not there.
is it better now?
A little better than before.
Okay.
Magnification should be one step more.
You have to be sure that the capsule analysis is completed. So first you remove the capsule and check whether it is complete. Now you can visualize that it is complete. I have done hydrodissection. You have to see.
Beautiful rexis. Beautiful. It's oil centered, very circular, correctly sized. But in case of
This should be ensured that a complete hydrodissection is there, and I am using 2% methyl cellulose only. I am not using any different viscoelastic, and most of my cases I don't use. So this is the chopper which I am using. It has a blunt tip, and inner aspect is a bit sharp. And my setting is for grade 2. IOP is 36, which I maintain, and aspiration flow rate is 37, and vacuum is 500. So with this, I use balance tip. So we have to be sure that our fluid wave is going perfect. Dip the wound slightly, and then you go through the side port. Remove the viscoelastic. Embed the tip into the nucleus. Chop it. So multiple small chops are done, and
Great, looking like a little harder than NS2.
yes, this is good
3 to 4.
because such cases are good to chop. If it is soft, then you can cheese wrap. Now I will go to Phaco, my different setting for the aspiration, and I lift the nucleus piece, bring it towards the center.
Sir, what is your chopping? Is it a lateral or vertical? Sir, in this case, would it be better if your tip should be sharper one?
No. I really, even in my hardest cataract cases, in brown cataract, I don't use.
Okay, that means you are not using in your hands, you are quite comfortable with this one.
Yeah. I use a single chopper, even, and in very soft cataract, I use a iris repositor.
No, usually people in this vertical chopping, most of the people are preferring the sharper choppers. So that is a question to me. And in
I don't think that is very required, unless until it is a black kind of a cataract.
correct. Okay, sir.
So now I will go to Phaco 3 node epinucleus. So that if there is a surge, you don't damage the posterior capsule. So this cortex is there, and I use a bimanual irrigation aspiration.
Sir, how your setting varies from balanced tip to normal tip?
Balanced tip is better.
And settings, any difference? Like
No.
balanced tip, you have separate settings, and normal tip.
I use this tip in all my cases.
Same setting in balanced tip, normal tip, all same.
Yeah, same tip. Even in soft cataract, I use balanced tip.
Yeah, but in settings, like in like a vacuum, power definitely according to the cataract. Like balanced tip, we need to use a less power because it's more powerful. So
Yes.
definitely for as compared to normal tip, in balanced tip definitely will keep lesser power.
Balanced tip, I use the same power and
Same power.
according to the grade, and I modify it with my foot pedal. So important thing is that there should not be any leak from. Can you remove this tubing from the? Thank you. So this is how we go. Hold the anterior edge of the cortex, pull it towards the center. And so rub it, so it will come. Is it, the posterior capsule is visible?
Yes, sir, yes.
So I will go to the polish mode and polish the posterior capsule.
Will you also do the polishing of the undersurface of the ALC?
No, not necessary. I will go back to the cortex mode. Do we have Phacoemulsification? So everything should be done under visualization. If any air bubble is there, you just remove the air bubble first. Rub the. So my posterior capsule is completely clean. So now I will implant the lens. Can I have some viscoelastic? 2.8 millimeter plate. Keratome. So because we don't have the injected system for 2.42 millimeter, so I am enlarging my wound to 2.8 millimeter.
Interrupt, sometimes the people become small. So preoperatively, do you prefer to give some drops like NSAIDs in all cases?
No.
That's more important.
I will require. This is injector system is. This is not an injector system, so it has got a rotatory system. You have already loaded, so I will not do a hydro implantation. Otherwise, I could have demonstrated a hydro implantation. They have already loaded the lens. This is Alcon Clavion lens, and this is a screw type injector system. This is the cartridge I am using for the first time. You can see the lens is moving further, battery should be inside the tunnel. This is a slow injector system. Lister hook. No, this is a chopper. Can I have a viscoelastic? Lister hook. Dialer you can give, any dialer. So I am pushing the lens inside the bag. And then now
Excellent Rexis, sir. Excellent coverage, 360 coverage of the IOL by Rexis.
now removal of the viscoelastic from the interior chamber first. Remove completely, because if you leave behind the viscoelastic, you will have reaction, corneal edema, striate keratitis in the immediate post-operative period, and maybe rise in the intraocular pressure also. So this removal of the viscoelastic I do thoroughly, and now I will go behind. And with my irrigation port. This is my irrigation port which I am always using in my left hand, and I go behind and remove all the viscoelastic from behind.
Sir, regarding the sizing of the Rexis, what is your advice to the juniors? So you have done it, like you are a very perfect surgeon, a very senior surgeon. So what is your advice? Therefore, bigger or smaller?
Optimum size is 5
Yeah, definitely, but for the beginner, sometimes it's not possible.
Yeah.
So ideally, they should go for bigger size.
Bigger is better for phacoemulsification. If you are doing, then your phaco will become easier.
Yes, definitely.
And otherwise, you can damage the arterial capsule while chopping and while removing, while doing cataract surgery, phacoemulsification. So my wounds are perfect.
Yes. So actually, all problems starts with small Rexis. What the beginners, they face problem because of the small Rexis.
I will focus on the wound now and check.
So the size of the Rexis, I think for the beginner, the first try to complete the Rexis. This is the most important. Whatever the size, whatever the shape. Then if you have a softer cataract, I think you go for the larger Rexis, because very difficult to crack the nucleus. So if any problem, any case, you can just prolapse the nucleus and you can do extracapsular phaco. And so the harder cataract, even it should be larger, because handling. But in between, if you do the too much larger cataract, it's the nucleus is tumble within the bag. Then it is very difficult to divide. So it should not be larger than the 6 millimeter or 5 millimeter, 5 to 6.
Then it becomes difficult to do phaco.
Yes, exactly. Nucleus is tumbling.
Surgery is over. Thank you all.
Wonderful surgery, Dr. Basin. Excellent. Beautiful surgery.
Thank you, sir. Thank you. अच्छा हो गया आपका operation.
Now coming to the Rexis size once again.
Yeah. So Rexis size should be on the larger size. In most of the cases, we can err on the larger size.
Yeah.
But in cases like a premium IOL, you should plan it up an optimum size Rexis, or maybe if it is smaller in the beginning, then you can enlarge it. And in some cases, sometimes I can show you how we enlarge the Rexis with the micro instruments, micro scissor and micro forceps. So we can enlarge it and make it a bigger. That we do in all premium cases. So that the lens doesn't pops out and it is well covered 360 degree all around. And there is no capsular phimosis syndrome also, because that will, when the capsular phimosis occurs, that will change the position of the lens, and it can go anterior or posterior, and the IOL power will change.
So we have seen you have used cystitome. So what is your advice for the beginners? Forceps versus cystitome, needle.
That is the personal choice, I tell you. Newer generation, they are more well versed with the utrata forceps.
Yes.
But I have learned it since 1995 I am doing. So I have learned it with this cystitome. So, and one important thing with cystitome, I would like to give the finer tips that I will show again, that cystitome tip should be nearly 1 millimeter long. It should not be too long, it should not be too small. If it is too long, you will err on a larger axis, because your stroke will be larger, more deeper, and so then it becomes difficult to control the axis if it is too large a needle. That should be kept in mind. And if it is too small, then it becomes difficult to do the capsular axis fold the capsule on the lens itself. So it should be less than 1 millimeter or almost 1 millimeter in size.
But how you manage like elastic capsule like hypermature cataract, pediatric cataract, subluxated cataract, where doing rhexis with a needle is difficult.
Okay.
So what should be your advice in those type of cases? Other cases we can manage with a needle.
Yeah, in those cases I use scissors, micro instruments, and to do the capsular axis. And I go through paracentesis incisions, because that gives me a better control. I like it. Maybe I can show in this particular case.
So this is a hypernatural cataract.
Yeah.
Right eye. The CD count in specular microscope is 2533 cells per millimeter square. IOL power is 18.5. So let's see. And VVT lens is we are going to implant the VVT lens, Clarion VVT in this patient.
Yes, sir. So let us see.
Let us see. Now over to Dr. Vasin.
Thank you.
It's looking like an intumescent mature cataract, sir.
Right.
Swelled up lens.
Mature cataract.
Yes.
At places, I think there is a fibrosis also of the anterior capsule. So I will require paracentesis also.
Focusing is not clear, sir. Can you just refocus?
Paracentesis. So in this particular case, I will go for. Is it well focused?
No, sir. No, it's not. Not yet, sir.
Sir, would you prefer the microscopic magnification to a lesser magnification?
Yeah. Is it okay? Or should I reduce further? This is better?
High. Little bit high, sir, little bit high.
Okay. You want high? Some more?
As you feel comfortable, sir, no problem.
Is it okay now?
Yeah.
So, I will make a side port incision first.
What is your position for side port? Which clock hour? You are sitting on the temporal side.
I am sitting on the temporal side.
What is your idea?
It is around 5 o'clock or between around 5 o'clock.
Okay. And 180 degree opposite?
Yeah. Not exactly 180 degree.
Okay. Less than that. Okay.
I will go into the substance, see the tip, and then dip the heel of the blade, and then I will use trypan glue. Thank you. So what I have done is, there is a trypan glue in a syringe and there is air in front. So first air bubble is coming and then trapping tube. So with the same syringe you can do both things.
So is it really it's required air to be going first?
Pardon me?
So, is it really required air in this means state? Can
Yes,
you
yes.
use just 3.2 without any air?
2.2. No, I always use air because then the staining is better. Otherwise, you will have to keep for a longer time. You have to keep the trypan blue dye for a longer duration.
What I have learned is that when you please inject air bubble, the air bubble will remove the aqueous, and so there will be more trypan blue for staining the entire lens capsule.
Mm-hmm. Yeah.
Actually, air also gives tamponade, that gives better staining. But nowadays I don't use, but I don't feel any difference between giving air and not giving air.
No, air helps to some extent.
Yes.
Because otherwise, if you don't, earlier they were saying that it helps in, there will not be any damage to the endothelium if you put air.
But most important is the tamponade, because that bubble gives tamponade to the anterior capsule. That gives better staining.
Yeah.
Yes.
Remove all the air bubble.
Yeah,
Otherwise, it is going to come and the visualization will be difficult.
So which viscoelastic are you using, sir? HPMC?
Yes.
Okay. Well, what is your advice regarding use of viscot in this type of hard cataract?
You can use viscot also, but I think this is enough.
But for hard cataract, if you want to
hard cataracts, brown cataracts I use.
definitely to see day one clear cornea, definitely viscot is necessary.
Sir, Hilon, can we use this Hilon?
Yeah, Hilon or viscot. I use a viscot in this case.
Yes.
So staining, dense staining is there, and there is a liquefied cortex is coming out. So I will aim for a smaller axis.
So you are planning for two-stage axis?
Yeah.
Two-stage.
Empty syringe. Yeah, the other one. 2 ml and 1 cannula. I will remove the cortex, the liquefied cortex from the anterior chamber. I am using, and this I will be doing through the side port.
So in this type where the cortex is leaking, definitely viscot or high viscosity viscoelastic definitely will be much useful, because that will tamponade the anterior lens capsule and there will be less leaking of the cortex. No, sir?
But I want that cortex should come out. Because that is going to increase the intralenticular pressure.
But you
so
are
the fluid cortex, if it comes out, and if you have aspirated, so your
but you want also that should be in a very controlled manner. If it is uncontrolled, that your axis will run away. That is also important, because if you are planning for a smaller axis, then I think the leaking cortex.
just see. My 2 instruments or forceps are there. So I will require forceps. This is a micro forceps.
Yeah.
Okay. But I will go through my side port incision. Is it visible?
Yes, yes.
Do you prefer to give IV mannitol or oral glycerol before pre-op?
No.
Yeah.
The nucleus is quite hard.
So, would you prefer to hold the eyeball with some
Yeah.
instruments?
Actually, my incision is.
For the beginners, I feel while doing Rexis, it's better to fix the globe either with the left hand, either with the forceps or with the cotton bud.
Keep the globe in primary
Yeah,
position.
to keep the globe in primary position.
So are you spiraling it?
Yeah.
Yeah. Good, sir. Very good. Fantastic. Beautiful Rexis, sir.
Thank you.
Large.
With only HPMC, it is very difficult to do this type of.
Yes,
So
definitely. And yes. And nowadays, I have stopped using HPMC. In all cases, Viscout and Hyaluron. All cases.
This is the different camera.
All cases.
Micro dissection for, because this is a flat camera.
Actually, regarding Viscoat or HPMC, I will here agree with Purandavasin sir. Even I have used Viscoat, and sometimes I feel that injecting Viscoat will tends to extend the Rexis. I don't know, I mean, because the fluid which is there is not able to come out, whatever sir is told. It is my experience. I also prefer to use HPMC.
Actually, what Dr. Bhasin, it will be in a single state. So, when you see smaller, 2 to 3 millimeter, then aspirate to use cortex, then enlarge.
I'm focusing it, and then
Focusing is not clear, sir. Yes, now it's clear, sir. Yeah.
See, we are using for last 3-4 years.
I will do. AC is not working. Hydro. So is it okay? So now I will do hydro dissection. In this particular case, hydro dissection is very, very important because you have to check the elevation of the nucleus tip. And although the liquid, the milky cortex is there, so that will help us in rotating the nucleus. Then I will now go for grade 3 cataract. So my settings are different. My tip is properly exposed because I have to bury my tip into the substance or nucleus. So if it is too small, then it is not going to hold it. The sleeve will restrict my barrier of the nucleus. Yeah, we will start with 3. If I find it difficult, I will go to the setting of remove all the liquid, and again I will go for a direct chop. Embed the nucleus tip into the substance. Can you go to yeah.
How much is your vacuum and power, sir?
Vacuum is
Vacuum and
650.
okay. Sir. Power, sir?
Power is torsional 70. Yeah. I have chopped it in the periphery. You can see the cleavage plane, not in the center at the moment. Is it well centered?
Yes, sir.
Yes, sir.
I am checking my cleavage.
once you have removed one quadrant, your half of the work is done.
For beginners, will you prefer to tell that in such case, in such hard cataracts, better to have two heminucleus first and then
Stop and chop.
yeah.
So for the beginners, I think they should go for stop and chop technique. They should adopt it, make one tunnel, divide into two halves, and then they can complete it. Now one thing is important that I don't, after one small quadrant is removed, you have got enough space to chop it. So then you make multiple quadrants. Otherwise, if you remove all the quadrants, then it becomes difficult to remove rest of the bases, because the remaining nucleus will keep on coming, and my tip is away from the cornea, and it's not very close to the cornea. And with my second instrument, I am pushing my nucleus back. So I will cut it into two first.
Are you stepping down your settings in this like last fragment? Are you stepping down or keeping the same settings?
I will step down. But before that, I will put some viscoelastic.
Yeah, to protect the posterior capsule. Yeah.
Posterior capsule, and I have come out at the right time, because the BSS is also need to be changed.
Ideal teaching, sir. Actually, before emulsifying the last fragment using viscoelastic, especially for the beginners.
You have to step down.
Yes, definitely.
And, you have to come out, take a break, and push viscoelastic, and coat the endothelium as well as the posterior capsule, and then when the cortex or epinucleus only is left, because such cases, as you can see, there is no cortex at all, no sheet of cortex.
The posterior capsule is fully exposed.
So don't, because surge is there, and that will remove all the viscoelastic. All done. Plain forceps, uterata forceps, uterata. Yeah, you can put that, this one. Should I increase the magnification?
Yeah, yes, sir.
This is a tooth forceps. I just want to remove this strained capsule, or maybe I can push it inside. So, lens. I'm sorry, I didn't remove the air bubble before. capsule, but it is not mandatory to do. Remove all the cortex from 360 degree. There is some cortex in the posterior capsule that can be polished. Now PC is very clear. We will fill the chamber with viscoelastic. And you can see there is some fibrils on the posterior capsule. So that also I have polished with the viscocannula. So there is no cortex at all. I am enlarging the wound. This is a UVT lens. So again, the same kind of injector system, and I will require a sensitive. Engage the cartridge in the wound, push it into the bag, then push it further, and with the same injector system, you may push the lens inside the bag. Thank you. Focus it throughout. For the beginners, I tell you that every time you should keep the things where you are working under focus. Lens is nudged inside the capsular bag. I will place it horizontally. You can see that this lens has got a central button which will stretch the focus of the lens, remove all the viscoelastic. So this is a hydrophobic acrylic lens. It's a beautiful lens which gives us the intermediate vision without compromising the distinct vision at all. And there is no glare, no halo. It's based on hydrophobic acrylic platform and Clarion platform. So it stretches the focus and that's how it gives you the intermediate vision, and there is no starburst, glare or halos present with these lenses. It is as good as a monofocal lens, and even in the compromised cases like having some macular pathology or having a optic nerve pathology, you can use it. So I have completely removed all the viscoelastic, and lens is well covered by the capsular axis margin and well centered. Capsular axis, all 360 degree. Wound hydration should be optimum, should not be too much. And
it's an excellent surgery, sir.
thank you.
Nicely done.
So,
Some air bubble has come. Can I leave this air bubble?
beautiful surgery, sir.
Or I will remove?
But in this type of cases, there is chance of rexis extension. So what do you advise? Like if rexis extends, then what will your like a plan B?
Plan B should be that you should complete it immediately and extension wherever it is. You bring it down and you can complete the phacoemulsification in the experienced hands.
Yes.
And better not to implant a premium lens. A simple monofocal lens is good enough.
Yes.
Or these kind of lenses can be used.
So a strong no in case of VBT, in case of rexis TR.
For premium lens.
Premium, any kind of premium lens.
Good. Complete. The case is over.
Excellent, sir.
The overlap of the gastroaxis mark is there. Any question?
Yes. Any question from the audience?
Sorry. Dr. Basin, what steps do you take to prevent Descemet's membrane detachment? To prevent Descemet's membrane detachment? How to avoid this detachment?
I think our instruments should be sharp enough and our wound should not be too small. Otherwise, then there is a high chance of Descemet's membrane detachment. And secondly, the tunnel should not be too long also. If it is too long, then you are bound to get it done. With both my cases, I have not got a Descemet's membrane detachment. As you can see, multiple times I have entered inside.
Yes.
And while passing, your instruments, your cannulas, they all should be of good quality.
Sure.
That is very, very important.
And what should be the position of the wound, the side port and the main tunnel?
Yeah, I don't make it at 3 and 9 o'clock position.
Now, it should be inside.
It is at 4 or 5 o'clock, and here it is, on the other side, it is at 8 o'clock meridian.
Now, regarding sideboard, should it be in clear cornea zone?
Pardon?
Now, for side port, should I place it on the clear cornea?
Yeah, it should not have the clear cornea. It should be on the anterior limbus, where the connectiva ends.
Sure. Okay.
So if it is anterior, then you will have to, you are going to distort the cornea. While passing the instrument inside, you will be distorting the cornea and your visualization in the anterior chamber will be poor. If it is clear cornea. So it should be on the anterior limbus, where you are not damaging the connectiva.
Okay. Thank you, Dr. Basin.
If it is posterior, then it will damage it is going to balloon the connectiva. That also will be a problem for visualization.
Good morning, sir.
Good morning.
Can you please repeat the concept of Purkinje image and the lens position?
Yeah. The Purkinje images are the reflex of the microscopic light. In Zeiss microscope Lumira, as you can see, there were 3 Purkinje images.
Yeah.
2 are circular and 1 is a bit rectangular. So these 3 will center the eye. In this particular case, the case was not done under topical anesthesia. The patient could not visualize. Otherwise, we ask the patient to look into the microscope light. I usually ask the patient when we do toric lenses or multifocal or this VVT lens for the centration. I ask the patient to look into the 3 small lights. So when the patient, this is the visual axis of the patient. So our lens, multifocal lens center and the VVT lens, they should be centered with these Purkinje images.
Okay, sir. Thank you. Thank you.
Navneet is getting ready and with his patient. Any other question?
Next surgery is by my friend Dr. Navneet Toshniwal. We were roommates in Shankar Netrajyoti in 1993-1994. And Navneet has his own hospital, Navneet Hospital at Sholapur, Maharashtra. He is a very good teacher and he has several books on phacoemulsification. So let us see his surgery. Over to Navneet. Residents who are not aware of his book Simplified Phacoemulsification. It's a very good book on basic phacoemulsification explained in a simple way. So they can have this book. Doctor. Yes, sir. You can. You can go to hall, sir. Yes, sir. Excellent surgery. Just we are very grateful to Purandar Vasin sir. He came all the way at this time of Arjikar incident. But since we decided to have this, it is such a incident that I could not even ask many doctors to come. Because it's a so painful incident, but we thought it will be recorded and live telecasted, so many people will see later on. That's why we are having this meeting. Thank you, sir, for coming all the way. And
thank you, Dr. Mohanta. You have a beautiful setup and your team is also very good. I appreciate your the nursing team and the assistants. They were wonderful and I didn't have any problem, although the setup was new. But thanks to Arka for giving me this proper machine and setup. And the microscope and everything is wonderful. Really perfect. Surgery becomes very, very easy and I am very, very comfortable here. Thank you.
Dr. Manush, you can discuss something. Dr. Parvez, you can discuss something. Navneet will take another 2-3 minutes.
Okay, okay. Yes.
Pujita, we want to see your pitch upper.
Yes, I'm sure.
We are eagerly waiting for that. You have to show how the beginners can exploit that pitch upper in all the cases.
Okay. Fine. I will show that.
Dr. Manusha,
Meanwhile,
let me ask you some question. In the meantime, what steps do you take to for compromised optic nerve? Optic nerve. Say patient is suffering from advanced optic glaucomatous optic atrophy, and he is getting cataract. Do you take some extra steps to prevent further damage to the optic nerve?
I give IV mannitol. Like, first, you have to see whether the patient is required, only cataract surgery is needed, or combined surgery is needed.
So this is a patient.
That's the first decision.
Mr. Gopal Chandra Mondol. He is suffering from cataract in both eye, immature senile cataract plus posterior subcapsular cataract, and left eye is going to be operated by Dr. Navneet. Biometric is 21.5, and which lens is that? Lens.
He's going to do SICS or Phaco?
Lens, which lens?
Phaco?
Region T, trifocal foldable iron, hydroid trifocal foldable iron. It's a diffractive refractive optics, advanced 360 square inch.
So why superior rectus, sir? Why superior rectus?
Just to make things focus. Concentration.
Sir,
Is it necessary superior rectus in Phaco cases?
This is what exactly what I am doing in my routine practice. I do most of the cases chop and chop technique so that I can do on any grade of
do the, even the, in many clear corneal, many practitioners, saline system, many practitioners, they are doing clear corneal incision with the help of crescent. What is the advantage of crescent? It will give the fantastic pocketing. And under that pocket, you can do your keratome incision fortunately. This is the disadvantage of the limbal incision, that bleed, sometimes cauterization is needed and all that. Now I will do the side port. This is a curved MVR. Now everybody is shifting to this because of the fantastic curvature. This is almost 90 degrees to the two side port incisions. Is the side. This is the discussion. This was the discussion whether with air bubble, without air bubble. Many people are telling you can do without air bubble, but everything is correct. So directly I start with the mixing this with the aqueous, the air bubble, air bubble, air bubble, air bubble. Thank you. Very good. So then I put, because chamber is not collapse, otherwise when you are putting the air bubble, sometimes you hit the, no, not this, tripandio again. Tripandio, dry, yes. Thank you. As such no need, but this is the way you just pour. Now, dye. This is methyl. Methyl cellulose. Heavy coat you are having. Can you give me? Yeah, please give me. Actually, hydrocode is having a little bit big cannula. Viscot is there, very nice. Thank you. So I will use the Viscot, which is a very important tool. Actually, Purendra sir wanted to do that. Many people have asked this. So this is the very important way to put the Viscot. I have written in my third book, if you will mix these keratome, you will give 2 buckets. So this is the what we have learned today with Dr. Bhumi. Just straight incision. Finish. No need to give the valvular and all that. I agree with that. The Scotch. Please try to see this, that your anterior chamber is with only one solution. Visibility is fantastic. This is the way to remove the put and remove. Now, no. Microrhexis per step. I am showing you the instrument which I am designed. This is the Toshniwal microcapsular axis per step with this unique design. Many instruments are in the market from Lumax and ST, but this is related to anatomy with its unique shape and design. Go through side port, start in the center, catch. One principle, just I keep it in mind always, that your flap should move parallel to the iris. This is the most important point. And fantastic control over the capsule. Catch it for the beginner also. Now I started to giving this important tool. Because yesterday I was talking with Pradeep. For the beginner, you should give Mercedes. Once they run, then you can give the alto also, no problem.
100%, sir. 100%. Beginners, we should give Mercedes. Later on, we can use alto, no problem.
Yes.
100% agreed. Yes, definitely.
So this is the microcapsular axis per step. What is the significance is that chamber is stable. No need to go in and out, putting Viscot-like solution. It is not luxury nowadays. It is a need of the thing. And hyaluronate also you can use. Now this is a little bit, I will take the permission of Pradeep to show this. Last 15 years I stopped doing hydro. I stopped doing rotation. So this is the simple technique of no hydro. Give me the trench. Already I told you this is stop and chop technique. You check the sleeve, it is more exposed, no need. fantastic balance tip. Now we are putting, just do the trench. Focus on trench, maybe little bit big. Magnification or maybe less is okay, yeah. Continuous irrigation, sir, I want. That is very important, so I will not press continuously for that. Now see here, inferior rectus is in my hand. So two things inferior rectus is doing is the primary position and second is the counter pressure. I am not seeing today the nucleus of this patient size, but I generally see my patient on slit lamp before the elimination of microscope.
Appreciate your innovation, sir.
Yeah.
We are appreciating your innovation.
Yeah.
Definitely, inferior rectus definitely will help you.
It is the central trench.
Yeah, beautiful trench.
Stop and chop technique is the universal technique already I mentioned. Normal. Now this is so-called, according to Arnold Bomick, is the, you can say divider. I have used my name is a pre-chopper. Before chopping I am using.
Yes.
This is the unique design, two notches anteriorly, posteriorly curvature, which is parallel to the posterior capsule.
Yes, it's
And this is
Akausi.
This is not across.
Yeah, but it's like prototype. Yeah, yeah.
Post-nival pre-chopper from epsilon.
Yeah, yeah, yeah.
And then you just go like this, go in the groove.
Yes, beautiful tips. Definitely, very good, sir. Especially for the beginners, definitely, sir.
Exactly. That's a very important.
Beautiful, because beginners they face only difficulty in cracking. Beautiful, beautiful, sir. Your innovations.
Once you divide this, in our training program also I mentioned your 80% job is finished. Learn this much at our center. And what the last case Purendra has mentioned that one piece is removed, everything is removed. So according to me, once you do divide trench and division, your job is finished. Continuous irrigation should be continuous. Thank you. Now give me the chalk one. Now third instrument which I have designed is the chopper. Yesterday I was watching the beautiful surgeries of my friend Pradeep and he was demonstrating his chopper. It was very simple tool and he was removing the hard cataract fantastically. But here I have given the shape like cornea, half cutting of the Nagahara, inner sharp and blunt down. Now I will continuous irrigation, chop sir, settings of the chop. Now I will go in the substance. In slowly, see how the water wave is going behind. Again go, bring it to the plane of the capsular axis. Go again in the mass and this is the first chop, book picture. Then go here, lift it out. See, this is a fantastic cutting machine. So on this nucleus, cotton sir, this is sufficient. My chopper I don't use, now I am keeping the primary position actually. If the centering is there, centering is there. Now better? Yeah. See, this is the machine. I will explain something about this cutting of Alcon machine is by sharing forceps. So no need to engage. You just go at the edge and start. I have cut down the parameters actually. He was telling me 400, 500, but it is correct. And see, because there is no other instrument there, just keep your instrument at one place, everything will come towards you, that is the Phacoemulsification. Sir, chop please. Now the mass is very small and we are having the top machine of the world. So lift it out of the bag and start eating. Cotton side. This is the cutting by sharing forces. Patient is moving. Yeah, just be at one point. And inferior rectus is throughout the procedure for my horizontal or primary position. And that's all. This is the just epinuclear mode. You can do that and you can come out. This is we have to do with our Phaco machine. Now I am using the coaxial irrigation aspiration. That is also my choice. Visco I am putting. Yes, Visco. Can you give me the animation?
Sir, can you explain why your coaxial is choice? Because see, Western part we see that most of surgeons are doing coaxial, but in Indian scenario,
Choice for one reason, because it is connected with the sleeve. So incision architecture is maintained. Second, I concentrate one instrument only at a time. Two instrument, two mind. One instrument, one mind. Continuous irrigation, please.
But in case of small people,
You just go beneath the subcapsular plane. I have not done any hydro. I have not done any reflection. You can see how beautifully this mass is coming. This is not at all a magical show. This is certain principle.
but see
Because it is coming in total.
here people is fairly dilated, but what you do in case of like mid dilated or poorly dilating people?
Then there is the bimanual.
Yeah, that means you keep two things ready. Yeah,
Bimanual is the most important.
yeah. But sir, do you agree that when you use coaxial, because you are using a little bit longer tunnel, there will be more distortion. But in case of bimanual, when using two small side ports, so there is less distortion to the cornea and visibility is much better.
Yeah, you are right, but coaxial, because of the sleeve and all, there is no disfigurement of the incision, believe me. After the bimanual, sometimes there may be the leakage. This one. There is some nucleus or something stuck, which I have removed. And which lens now I am using from?
Western surgeons, they all use, I think most probably they don't have bimanual, and that's why they don't use this coaxial.
Very important. Now, here everybody is talking about the second instrument. When you are pushing it, it is 2.8, it goes very smoothly. If it is not well, now see my inferior rectus, finish. It gives the better control. Eyeball is at a steady position, and we are finished. No need to put, no visco. I generally don't use grinder. Just take the visco, things will begin, you just use the direction.
Is it under block? Block. Topical, but injected few for superior and inferior rectus. Subtenons.
Our Indian companies are working very nicely with the optics.
A nice demonstration, sir, for teaching, especially your innovative way to keep the eyeball in primary position by using two superior. I have never seen. This is the first time I am seeing that you are using two superior rectus, two recti for keeping the eyeball in primary position.
Everything I have taken from
Yeah, especially definitely this will be very useful for the beginners. Yes.
to show these things.
Yes. We are.
I done surgery of my mother 6 months before. She is 81-year-old.
Yes.
I have taken superior and inferior.
Yeah, we are appreciating your innovation, sir.
Yeah, because anything can happen because of the position.
Yeah, keeping eyeball primary position most challenging task.
See, the primary position is throughout fantastic.
Yeah, definitely, definitely.
And you will see
Yeah.
that. I have not given any block.
Yeah. We are appreciating, sir.
Yeah, and now there is some cortex behind the endothelium, so I will flush it with the Simcoe canal. Simcoe, you can attach the Simcoe, sir. And what a great team is the Pradeep is very fortunate and lucky to have such a fantastic team who is having experience of 15 years, 10 years, 8 years. Yesterday he has introduced me with everyone. And he is very fortunate and lucky the doctors who are coming over here to learn from him, they are also very fortunate, sir.
So in
Flushing, this is the flushing of the endothelium, reverse.
sir, in posterior polar cataracts, where we need throughout the chamber formed every time, do you prefer bimanual or coaxial cortex?
Coaxial and bimanual you are talking, sir?
Yeah, in
polar
posterior cataracts.
Bimanual is the choice.
He is flexible. Basically, he is
Stability should
You are
be there
flexible, sir. You are
with
flexible.
5 cc syringe. Or big cannula. Or give me big cannula. Big cannula or big syringe.
Sir, are you using this?
Now here, no, just let me know one point. 5 cc and 2 cc syringe. Now I have in a 15 days my first book, second edition is releasing, where I mentioned big cannula, my sister, this cannula. So here, in that one chapter I have added, how to complete the case with the 5 cc and 2 cc syringe. So use the 5 cc syringe with the, no, this is not, this is small, sir. You know this type. Yeah, this one. Yeah, correct. Whiteboard is better. It is not giving any, see, this is the cannula which I recommend. And here, please try to understand everyone, don't go 90 degree, go tangential. See the flow, but iris will be so stable, see. Because here then we are giving this step to the any doctor, anybody. Iris prolapse chances is there. One more. So 5 cc syringe gives stabilize and 2 cc syringe with small cannula is for finishing. Again I am showing this and you can go behind, very gentle. Yeah, go behind. See, simple way, finish, put it. In these cases, no need to do the hydration and all that of the wound because this is the limbal incision. One of the strong incision, according to me.
Sir, how is your post-op astigmatism in such case?
See, this is the beauty, no? You are doing so many SICs. Madam, stay cannula, 2 cc or 5 cc, full vision. Irrigation again. Spend some time here because you have to remove all the viscoelastic to avoid this post-operative complication and all that. So, some cortex I am seeing inferiorly also, but I am not going to touch that because the new setup you should not do unnecessarily anything. Yes, sir. And this is the, yeah, thank you. This is the finishing. Just put the 2 sister line. From side put, it is a tense eyeball. This is because of the limbal incision. Thank you very much for your patience hearing, sir. Thank you.
Thank you, sir. Beautiful surgery.
For your excellent surgery. So, there is one more surgery for you.
Yeah.
Sir, one thing I want to ask you.
Yes,
Do you see some?
Change, I will just cut it. Limbal, I will contract, so they will be ready with the second case. I will come on the mind. To say, tooth person.
Do you notice any ptosis in post-op cases?
Yeah, see, all these things are absolutely correct, sir. Anything can happen, and that is the reason we stopped doing these rectors and all that. But I want to take advantage of this, and in some case, 1 in 10,000, 5,000, 1,000, I will accept it. Thanks. I'll go for questions.
Sir, I have one question. Why do you prefer limbal incision versus as compared to clear corneal incision?
Yeah, definitely that answer I can explain when I will come down. Believe me, sir, Phacoemulsification works on your incision. Many times you are having the top machine of the world, and if the incision is leaky, you will not get what you want. This is the first thing. On the contrary, in our teaching, when I will give the opportunity to do clear corneal and limbal, doctors will prefer, sir, I want to do with limbal. I want to learn first everything, and then I will go for clear corneal. So I think clear corneal is fantastic, stable, very important, but limbal is the really best choice. On this big platform, I can say that there are many points related to that. Most important is the leaky, and it is more stable incision.
But you are under topical anesthesia. The patient is under topical anesthesia.
All I have done under topical.
But doing cautery won't be painful.
No,
Under topical.
you can ask the people. The patient has shouted, sir, during cautery.
But you have used subten on little bit.
Correct, sir, you are right.
So the next patient, 70 years old aged female. There is left is pseudophakia, right is going to be operated. Phaco plus IOL. IOL power is 21. Over to Dr. Navneet.
Yeah, this is a little bit hard cataract, but can you see this examination? You can see all the layers of the lens. So I have mentioned in my one of the book that if you could see all the layers of the lens, then it is called as a predictable phaco. If you can't see in mature cataract what Purendra Basin has done, you cannot see any layer behind. So you don't know exactly anatomy. So it is always unpredictable, because this is very important point for the beginner, that you should know these things, that you cannot be a very casual for this. Yes, this is already patient is blocked, but I have already mentioned this case we can do without rectus and all that, no problem. And the superior I have taken, superior rectus other advantage is that if you want to convert your case, suppose hard cataract, mature cataract, it is very easy to convert this. And not very big belly of the muscle. Little bit belly of the muscle, but then Gava tenon at a very small point you can take. With the consideration of the time, I will just explain. I have already explained my all steps. Madam, got it. Sir, can you increase the bottle height? Means, yeah, IOP, I don't know what the bottle height. No bottle height, it is the IOP. Limbal incision, actually we forgot, sir, because of the cosmetic purpose, we are not doing now.
So it's a little defocused and decentered also. Can you just recenter? Focusing as well. Yeah, yes.
No, same, 5, 15. Reset. Yeah, late, yeah. Now, see, here is the fixation with the superior rectus. Otherwise, this step, you do try to do this step, eyeball will go down. Again, a fixation with the superior rectus, so it is very easy entry. Now, many people are doing SICS also without rectus. But I don't believe in this thing, because you should take the help. Very important. Got it, sir. Yeah, enough. Side port, please. Yeah. Now there is a particular direction of this side port. It should be go towards center, and it should be the left side port should be 90 degrees to the logical axis. Fantastic blades from the Alphon. Little bit increase in the left side. Yeah, air. After this air. Yeah, air. Again that. Yeah, again that. Yes, thank you. So this is under the air over. Go now. Scott. You will take the advantage of this beautiful product. It is a combination of the sodium aluminate and chondrite. Keratosis. And then 2.8 straight. You can give the response. Yeah, this mixing of the.
Sir, can you have you used Indian version of his coat?
Of course, it is good, sir, but not as good for
Obviously. But what is your advice to the juniors? Because cost is a.
Sodium hyaluronate is the choice. Then you can use for corneal endothelium case Purkinje images, start, open, catch, yes, move. You should not only do, you should feel the surgery, feel the axis. This is very important. You can get the idea of the zonules and all that. And only because of it, the shape you can do so quickly. Old age is the problem in this case. So that is the reason I stopped doing more hydro, more rotation, because in the old age, if I will do that more, maybe the zonules can get damaged. Again, I will go with the Phacoemulsification. Can you increase to 100, sir, torsional? Can you focus down, sir, little bit? Little bit. Focus down, because this is the very important. No, opposite, opposite. Opposite, 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 opposite. Yes, thank you. This is very important. Here I can show you combination of torsional as well as longitudinal. Do 50, sir. So here is a combination of the longitudinal 50 and torsional 100. Is it okay? See, this is the combination. So both the thing we are taking the advantage in the hard cataract. So traditional as well as torsional. This is a very important and unique feature of this machine. You can take the advantage of both. I am putting the visco. I can see a little bit.
Beautiful trench, sir. Beginners should learn trenching from you. Because now,
Yeah, here we are using the pre-chopper, go to the base, and just touch the base.
beautiful,
Finish.
beautiful.
So this is the tool. Once the job is done, otherwise you will struggle for this state, and that is there. I will now give you the position of the chopper. Thank you. Very expert, very expert. I will take 1 2 people with me. Solapur.
With this pre-chopper, it is very easy. It looks very easy to
See, sir,
divide the
see the position. Do this simple job, sir. Because I cannot rotate more, no need also. Now you can increase the 500. Sir, vacuum.
Yes.
Sir, vacuum up. Jitna karna hai karo, 500, 600, yes. Flow rate 40 karo. Okay, sir. Or Phaco 2. Yeah. Now say, go in the mass, yes. Flow rate and chop. This is a horizontal chop. I do the chopping at the level of capsular axis plane. Enough. Quadrant. My chopper is out. Sir, there are 400 kar do yahan bhi. 40 kar do. Thoda quickly aa jaye. Yeah. Now I am in the centered safe zone and I am removing. See, this is the machine. Cutting efficiency. You just go near the piece, it will finish. Whatever the grade of the cataract. I will show you here something different. Sir, chop. Even this hard cataract, now I will just wanted to show. Quadrant, sir. See, just this is a cutting by the shearing forceps. I have chopped so many things, 2 3 pieces, but here I am just using the shearing forceps. See, in a 5 to 10 seconds, such a grade of cataract is finished. And this is called as a torsional technology and advantage of the torsional technology. And that is the reason I don't do more chops unnecessarily. Just at the plane of capsular axis, you just use the shearing forces. Advantage of that machine is that. And be away from cornea, hit it. It will go in at 5 to 10 seconds. Visco I am putting. There are some nuclear forces. It is because of the block. What is the disadvantage of the block? I will tell you. You will get hypotonic. And because of the hypotonic, pieces are hacking here and there. That is the reason patient should be normotensive before surgery. This is the biggest biggest advantage of the topical anesthesia. You keep the patient in a If you give the block, see, one piece I have removed. This is the advantage of limbal, sir. You can press the posterior lip of sclera to remove these things. In our Indian practices, we have to do all these things. If I will be in US, I will do clear cornea in every case. But here, I will love to do this. Go in the plane, go beneath the entry capsule. I am really thankful to Pradeep for giving me this wonderful opportunity. Many people, many doctors from Maharashtra are watching this. Especially my mother is also watching. She is very keen to see my each and every case. Thank you, Pradeep, for this live streaming. And this is the coaxial irrigation aspiration advantage. Lens is ready. Which lens? It is going smoothly. I don't know which lens. But whatever the lens principle is, put the lens parallel to PC. Parallel to it is a sensor one lens, hydrophobic lens, spherical IOL from Johnson & Johnson. We have seen already the fantastic demonstration of the PBT, Clarion lenses, Acrysop. These are the unbelievable products. Now here, just be the center. When you are in the center, use your parameters at a top level. When you are going periphery, you should decrease. So this is the way, and all the time you should tap the continuous irrigation, Joseph. I am habitual for that. Continuous irrigation, please. Please, sir. Yeah. Jonah. Yeah, I will be comfortable, otherwise I have to press continuously. Yeah, that is, I am taking advantage of that beautiful button. Yeah. Enough. Now give me the 5 cc syringe. Thank you. No. See, because of the hypotony, it is not very easy to remove. Madam, please to give that. Yeah, thank you. So there is some dusting here, you can see, go behind and flush it. Many times, no need to do the cap mode and all that. Flushing with the saline also remove the many cells. Give me 5 cc. Thank you, sister. And here, once again, thank you for my friend Pradeep, who has invited me at his center. I was so excited, and whatever I wanted to see, I have seen everything here. Such a small place, but 60, 70 people are working with him. And he has changed the scenario of this part of the world. I am really thankful to Arup, Urendra, he is my international friend. Again sharing. See, because of the hypotony viscot, because of the viscot, this is disadvantage of viscot. It's stuck to endothelium. You can give it the Simcoe. So flush this Simcoe. Flushing is very important. Because this is the disadvantage of this viscot, because it protects the endothelium. And that's why the material is there. I will stop now because we are eager to see the live surgery from my best friend Pradeep. Thank you. So these are some of the points we want to discuss with the block. Beautiful design of the Simcoe. So it is a flushing, reverse flushing of the endothelium. Be careful, otherwise you will damage the endothelial cells. Give me saline, 5 cc or anything. Yes, I will just form the chamber. See, that's the technique. Just go put something saline here and come out. It will seal automatically. No need to do any hydration, because I have lost 2-3 cases because of the basement detachment. But in clear cornea, you should try to do. This
Very nice surgery, sir. Thank you. Thank you.
Thank you very much.
We learned a lot from you.
Excellent and unique surgery, sir.
Thank you, sir. Thank you.
You have explained your steps.
Only simple way I just wanted to show, and what I am doing, I am showing, sir. Thank you for your patience. Thank you, sir.
Thank you, sir.
Thank you, sir. So the unique points are here. I want to give just 2-3 points, not as such for beginner, for everyone. Stop and chop technique is the universal technique you can do for the grade 2 to 3 cataract, hard cataract, soft cataract, any grade of cataract. You can do stop and chop. And once you will be expertise, you don't want to waste your energy for fringe, then you go for the direct chop technique, which is possible in grade 3, 4 and hard cataract. This is just my fun. I think everybody should go for one technique. One technique for 1,000, 2,000, more number of cases. And once you become expert, what I mentioned that, use the best things first. Once you understand the principle, you can go with anything. So that's the way we learn. And these different instruments as designed due to watching the difficulties of the doctors, and then I come up with these designs. Now over to Pradeep. Thank you, Pradeep.
Now the next case is 65-year-old female. There is cataract in both eye. The left eye will be going to be operated, and it has NS grade 1 to 2 cataract plus PSC. And the sir will be putting Technis aspheric IOL in this case.
Pradeep da.
So Dr. Navneet, you have invented lots of instruments. So how these things came into your mind? Because as a surgeon, I always try to think that I could be able to invent something, but it's very difficult because nothing is coming in my mind. So how it came in your mind to do like this?
I will give this credit to my international conferences too, and visiting the many people from different companies. And whenever I see new, I go through the science, I watch, I see that microrexis forceps. First I have purchased in 2000. It was $1,000. But I didn't like the shape and all that. Then I studied on that. Pre-chopper, 4 years I was studying. So it's not invention overnight. 2, 3 years, 4 years, you have to work continuously for this. And third thing is the anatomy. I always see the anatomy because many instrument companies, they don't know anatomy exactly. So once you guide them related to anatomy, it will be the best. Thank you, sir.
So, Navneet, tell something more about why you do you do this way all the time, peritomy and then scleral incision, even for your paying cases?
In paying also, already I mentioned I have done my mother's case with the same way. Why I am telling you, in any case if you want to converting clear corneal is easy or limbus. Especially those hard cataract, mature cataract, pseudo-exfoliation, complicated cataract, try to do with the limbus. Otherwise clear corneal is the good incision, If you, yesterday I have seen the 7-8 cases of Pradeep. Excellently he is doing clear cornea. So no need to go for this. But in teaching it is not very easy. If it is leaky, doctors cannot perform the next steps. So for teaching, I definitely recommend lingual. Once they are expert, then they go for clear corneal and do the phaco. Thank you.
So in this case, I am going to show the pre-chopper.
Pradipta, are you sitting in superior position?
Yes, yes, this is my position. I am a lazy man. I want to change positions for right eye and left eye.
Okay.
So I think you are also the same.
No, we do temporal. All cases temporal. All cases temporal. All cases temporal. Like cases comes through like that. 4-5 cases right, then left, like that. Goes on. But don't you agree that temporal, like incision, ergonomically and everything wise is much superior than superior? Definitely. Even the ergonomics, if you see the ergonomics, and also the anatomy point of view, definitely temporal is much superior. If you can see a good glow, and also the temporal limbus is much wider than superior. So astigmatic point of view also, temporal is much, as well as visual axis. So astigmatically more stable, yes. Yes, downwards. So visibility is a problem. Yes, definitely. Superior. Super temporal, yes.
So nice rexes you are doing very nicely. Yeah, circular, very well sized, adequately sized rexes.
Is setting superiorly, but the main port is you can say superotemporal. He can prove that position does not matter. Wherever you sit.
Slow it slowly. Application of the pre-chopper. Slow it slowly. So that everybody can understand. Yeah. Explain it.
Yes, this is the pre-chopper.
Yes.
The front is the sharp edge, and this back side is the blunt. And it's like a triangle from back side to the front side.
What is the length?
This length from here to here is 1.8 millimeter.
Okay.
And this is rounded.
So how you come to the figure of 1.8, not 2 or 2.5 or 1.6? How you came to this magic figure?
This from here, this vortex and the nucleus will be about 1 millimeter.
Yes.
It will go from nucleus surface 1.8. So it will be about 2.8. And that is enough for tracking the nucleus.
But don't you think that in harder cataract you need to do a longer length?
Yes, I have made one more, hard cataract I have not yet tried actually.
Okay.
This is the nucleus sustainer, there is a small ball at the top, and it is a round bodied thing. From here to here is 1.7 millimeter. Now I have asked them to make it little longer, so they have made one more for 1.9 millimeter. So this goes.
Do it slowly. Explain it. Where you are placing your pre-chopper? Sub-incisionally, below the rexus margin?
First this one goes,
Yes.
stays there,
Yes.
and just this one just goes in front of the rexus margin
Yes.
and embeds like this.
Yes.
And you go
Now,
and hook the
equator.
and two instruments come to each other. It has to be at the proper depth.
Yeah, beautiful. I have used few cases with your chopper you have given to us. It's really excellent.
This one, again, one more nucleus chopped into two pieces.
It's a great innovation, sir. Great innovation.
And the job is almost 70% done.
Yes.
Now we go and
Pradeep, if you can do you use it in very soft cataract. See, this type of cataract chopping with phacoemulsification is easy, but in case of very soft cataract where really chopping is difficult, can you please show that type of case with your pre-chopper? So that will be easier to understand the use of this pre-chopper. No, but definitely use of your pre-chopper will be easier, isn't it?
In those cases, it is difficult. Very soft cataract, separation is difficult.
No, I am not saying PSCC type of cataract, like NS2 type cataract.
Pre-chopping, you need something to chop.
No, definitely, but the application of the force is important. Application of the force. See, here is a horizontal force. So, in case of softer cataract, no. So, in case of particle chop, you are splitting it. But I have used in softer cataract. I think application of the pre-chopper in softer cataract is much looks sound than this particle.
Soft cataract, really we don't require chopping. You just can hydro and remove the nucleus and remove it. Yeah. And hydrodissection, hydrodelineation. Wonderful, Dr. Mohanta. And you are doing so.
Use that Baltic sustainer to protect the PC. You will rupture one or two PC and then you will learn it. This is Tekison from Johnson & Johnson. The lens has split, so we have to inject disco and flip it back. Next case, Nirajman.
Sir, it's an excellent surgery and it's so fast. It's so quick. It hardly takes, I think, 4 minutes, 3 to 4 minutes.
You also do manage the same.
We should not pay you if you take it so fast.
So you don't have any chopping setup in your paper machine?
Yes.
Sir, you don't need any
No, it's not just.
But not in all cases.
consider only.
No, actually, Minmoy is joking. Minmoy is joking.
Dr. Pradeep, you always do pre-chopping in all your cases?
No, sir, for soft cataracts only.
Only for soft cataracts.
Next is hard ones. I do submarine chop on that case. That is also, can say pre-chop by the handpiece.
Sir, what is your take on Oatly machine? Because I'm seeing that you are preferring Oatly machine rather than those alcohol machine.
I cannot afford alcohol.
So what Rexis size do you recommend for beginners, for those who will be using your pre-chopper for the first time? It should be a little larger, or?
First, maybe afraid of the larger nucleus sustainer. You are asking that?
Rexis size, sir, Rexis size.
Rexis size should be about 5.5. Should not be small. 5.5 or 5.75.
And also I feel staining the capsule with Rifanbo will be better because one has to be clearly see the rexis margin throughout while using the pre-chopper.
Pre-chopper, I think all of us should try in soft cataracts because sometimes we create a hole and it becomes a pain to manage after that. If we try to hold the thing, it just the nuclear material in front gets heated up.
How your pre-chopper differs from the Sohail Khan pre-chopper? Pradeep da? How your pre-chopper differs from Sohail Khan pre-chopper? Sohail Khan.
Sohail Khan, yes, I have used that. Actually, Sohail Khan had a very funny policy of
No, leave that. But technically.
marketing policy I didn't like. Then I thought this is a nice tool and I have to change the design and make it available at a cheaper price to everyone. So I thought, what's the
Really, we appreciate you. We appreciate your effort to popularize the pre-chopper because I am in that group. Really, we appreciate your endeavor to popularize the pre-chopper. Actually, after the Akahosi, nobody took interest to popularize this chopper. Sohail Khan took that. Next, you took that effort to popularize the pre-chopper. I think pre-chopper is is one of the instrument every surgeon should keep in their armamentarium. So learning extra is always better than not learning. So everybody should try learning pre-chopper.
This is the cataract. Tell me what is the grade?
Grade 5, 4 to 5.
4 to 5. This is hard cataract, sir. Image grade 5.
Yes. So are you using submarine in this case? Yes. I appreciate your submarine, how you popularized. I use all cases submarine. Pradeep, really I am thankful to you to popularize this technique. Yeah, definitely. Very good. Previously, I have tried woodcutter because Mahatma sir, but after stopped. Then when you started popularizing this submarine, so I tried. I incorporated this technique in my cases. Definitely, it's fantastic. It's fantastic. And the way you popularized, you have convinced whole world. Even Uday Devgan speaks all time speaks about you. So that is the most important thing. Technique, popularize the technique. See, Akahosi chopper is not that popular, no? He only used, but hardly 1% of surgeon in the world is not used that. But the way you took the effort to popularize this technique definitely is definitely is a great job, Libda.
Thank you. Nice words.
No, you are doing great. For the young generation. See, many young surgeons joined our DISA, so I asked them, how you learn? See, everybody gives you a reference. Everybody say that we have seen Dr. Pradeep Mohanto's video to learn that.
This is viscose. Goes fast. And now, under the viscose, then HPLC over the capsule, because viscose can cause wound burn.
It's basically soft shell technique.
Yes, modified soft shell technique.
Do you like to go for a larger axis in this case? It's a hard cataract.
Definitely. See how large and big the retina is, about 6 millimeter.
So no baby rexis. Always without Devgan says, no baby rexis, no baby rexis. No baby rexis. That always rings my ear when I used to do this such type of cases.
It's a good axis, sir. Well controlled, larger axis.
So bimanual rotation of the nucleus now.
Share.
90% photospheric energy, 480 vacuum, 48 flow rate.
Why bimanual rotation, Pradeep da?
Bimanual will cause less stress on the tuning wheel. If you try to rotate with one instrument, then you may cause more stress on the tuning wheel. You will push the nucleus more. Here you are within the bag. Within the bag you are rotating two instruments. One more idea is allow little more leakage in hard cataracts. Just give one cut
Okay.
so that the wound burn chances are lessened.
That means around 3 millimeter.
Allow more leakage of fluid around the handpiece. Now go inside the nucleus, push the nucleus little down, go inside the nucleus. And now like a submarine, keep going through the nucleus from
Rock hard.
towards the opposite equator. And just crack gradually, get a nice crack.
Excellent, sir.
Come down to the other side, sculpt once, turn the handpiece, put one side and separate the other. You have got complete division of two heminuclei.
Excellent, excellent.
Go through this phase. And we have divided this into two large fragments. Come to the other heminucleus. And this one also we have divided into two pieces. And now turn this here to the
No,
apex.
this is
Just go under the apex.
Konta?
Apply power and start it. Come to the other piece. Just go under the apex. Emulsify this. Get another piece in front. This is a huge piece. You can divide it into smaller pieces.
Pradeep, how different is your submarine chop from the woodcutter chop? Because it looks more or less similar.
Almost similar.
Almost similar.
Here what it does is
It fixes with the left hand.
goes to the opposite equator
Yeah.
and it is like a nail. It is
Yeah.
placed there.
Yeah. But you are not using that.
I just support the anterior surface and it goes along the handpiece in front near the equator. It's not nailed like a input cutter's blade. It's almost similar.
Almost similar, yes. But Pradeep, you have popularized it, really.
And now for this last phase, what we can do is can detach the epinucleus and
Most important thing is that you did not, when you do submarine, you did not have a very expensive machines like Centurion or other thing. This technique can be done in like ordinary Phaco machine also, isn't it, Pradeep?
can be done by any machine.
Any machine, yes, yes. You don't need this fancy 600, 700 vacuum.
Let me protect the cornea as well as posterior capsule for the last piece.
Any machine, but the torsional energy, which is very important for cutting such a type of hard cataract. This is our experience. It
Yes,
gives
that
us
is
a very
true.
good.
For emulsification of this hard cataract, the torsional energy will cut it like butter. But if you don't can afford that, you have to find out ways to manage such hard cataracts with your
So this tip size looks a little bigger than the balance tip size. Orteli. Okay, yeah, yeah. No, the Phaco tip size.
I think it's a flare tip.
Cobra tip.
So the front end of the tip is much larger than the normal tip.
Cobra tip.
Pradeep, can you please repeat the parameters you are using in this mode?
This is actually called easy Phaco tip.
Okay. Continuous mode. And the flow rate was? Acha. It is okay. It is rather high, the flow rate. Okay. Okay. For Oatly has a wonderful grip on the lens. It has rather a hold on the lens.
Hello. Why don't you use bimanual? Why are you using Simco? Why you are not using bimanual? Why are you using Simco in this case?
I didn't make another side port. I think just if I make this side port 0.2 or 0.3 millimeter more, then I can manage with Simco and one side port.
Okay.
So, and the side port is 90 degree away from the main one.
Oh.
So it will reduce the astigmatism produced by the main one.
Okay, that is the reason.
I don't want to make another side.
Okay.
Below 40.
This is Supercook from Apasami Associates. Galaxy Gold from Apasami Associates. Go under the lens and irrigate. Get all the visco out from behind the lens. That is the visco that is trapped between the lens and the posterior capsule must be removed. Time to the level. So we are finishing this case in 12 minutes. Form the antechamber in this way. Just give a forward push and come. And this seal, intraocular pressure is normal.
Excellent surgery, sir.
Needed to mention.
It's an excellent surgery, sir. Grade 6 cataract in live surgery.
As usual, Pradipta. Did not to mention.
Thank you, sir.
Thank you. Now we are going to have a very tough case, uveitic cataract. I get this case for Purnendra Vasin sir, but they wanted to do VVT, alpha VVT lens, which was not available for this patient. So I have taken up this case. I asked Purnendra Vasin sir's tips for this case. I don't know
Yes. Netrajyoti, he is a wizard. So all technique in his hand works so easy, no? Whenever we see his surgery, it looks so easy. He is a living wizard.
But he's a definition of expert. Makes difficult thing easy.
It's a complicated cataract, I think, sir.
Yes.
Yes. So, would you like to use some pupil dilating devices? Sir? Would you like to put some pupil dilating devices in this case?
Yes, that has to be done.
Okay.
Let us see how it goes. First, this incision.
People in memory are also there. Sir.
Now, I have seen on slit lamp that there is a small gap at around normal block. Through this gap, I will go behind the iris and inject tricondylar. So that it has gone all around. You can see now the capsule is fibrosed. I just speculated also. Now let us see if we can separate this by the iris spatula. Yes. Now I do control space. Yes, sir.
So, sir, you usually prefer BXing. I have seen in YouTube videos.
Yes.
So, do you prefer this BXing over malleolin ring if means the price is not a concern?
Malleolin ring, I have rather no experience, so I don't know how it is. Maybe better than this, but this is what I have used. I need another side port in this case.
So, do you feel any subluxation is there if the lens is phacodonosis, I think so?
Let us see what is there.
Actually, my preferred choice is Malugin ring. I and
Sir, would you like to again put some glue to stain the entire capsule?
yes, definitely, because visualization is not that good enough.
So there is visco inside. We just charge the capsule and inject visco.
Yes,
And it can be for visco painting.
visco painting. Yes.
We in our hospital nowadays using Gupta's ring. It is the pupil is more larger. Yes.
No, actually, Pudipda, if you could have used iris hook in this type of cases, so we are seeing there is some little bit subluxation is there. So iris hook can serve the dual purpose. That can enlarge and at the same time it can fix the anterior capsule also. Isn't that right?
Let us see. You can remove everything and use iris hook also.
So the rexis has extended.
Rexis cannot be completed. There is so tough. You have to cut it. Since the
Are you doing slow motion phaco, sir? I mean, you have reduced the parameters, flow rate.
Excellent, sir. Excellent. Excellent.
Because patient have confidence over you, that's why he is sleeping.
I am in the OT, I am seeing the fantastic confidence actually, what the way by which he was moving and without any pressure and all that. Congratulations, Pradeep.
Thank you. You are such a great teacher. The way you explain these steps of surgery, just fantastic. The BH is being removed now. Yes, we have to just pull it out. Vasil sir, please have lunch. We have to start by 2 o'clock. Purendra Vasil sir.
Sir has already gone from this side.
Okay. They have gone behind the lens and removing all the disco.
Will you not use subtenor or intravitreal steroid, Kenacort? Subtenon. But ideally, because you have stretched people so much, ideally speaking, one should give subtenon depot steroid, or maybe transgenular intravitreal.
We'll see the reaction. Subtenor we can give in the OPD also.
Yeah, but practically there is no harm to give this steroid. That is correct, sir.
Would you prefer to do a PI in this case, sir? Peripheral iridectomy? PI, sir.
Peripheral iodine. Not necessary. Chamber is quite deep. But asking the question because can you see that a pupil block can occur in future? That is not according to you. Correct. And some sphincterotomy is already has been done, sir. So it will work as a, it will relieve the pupillary block.
You were asking about
May not. You can think.
Just introduce Kenacort and we wash it out, and some molecules will remain, and that will take care of the inflammation.
Very good.
But you were asking about whether to use subtenon Kenacort. I don't think it is required, because all this thing, whatever we are doing, using manipulating the iris and all, nothing happens, no extra reaction occurs. You see, even if he would have not used Kanakaut intracamerally, it would have become quite, the eye would have remained quite post-operatively, just to increase. Wonderful case. Pradeep, you have done very nicely. And, but
don't like react once the inflammation starts. So give steroid as a prophylactic. What Pradeep is saying is that we can give subdermal steroid in the OPD if I see inflammation. So my point, so give it prophylactically. The only disadvantage is that if steroid respond that, then
this thing is very nice. Actually, we, differentiate between two things. One is whether it's a case which is quite eye per long, or whether the case we have made quite in recent past. So if we have made the eye quiet with oral and other steroids in recent past, then in such a case we have to give the intravitreal triamcinolone, maybe half dose, maybe full dose. But in the case like this, where there is a long-standing quiet eye, but because of the small pupil, a hypermature cataract, long-standing cataract, complicated cataract, the eye is, this is the. But you never.
You would have gone to do this surgery. It will be the same way what Pradeep has demonstrated, or you will change some steps on that?
Maybe I would have tried stretch pupilloplasty and seen if we could get additional, if we could get a adequate pupil size, then I would have gone for that only. And I don't use the BX or ring or the iris retractors. So BX ring is good, but all of you must have seen that the size of opening which we get is less than 5 millimeter. So that is the shortcoming of it. And in some cases of this kind, you get a zonular weakness is also there. And maybe the peripheral, the anterior capsule is fibrosed in the mid periphery. So then it is unable to do the capsular axis in such cases. But otherwise, he has managed it so well without damaging the zonules, without damaging the endothelium, and still performing phacoemulsification so beautifully. I really appreciate it. Yes. And stretch pupilloplasty, not too much of stretching is required. But if you get a 4.5 millimeter, 5 millimeter, this size of pupil size with the stretch pupilloplasty, that is enough. No, you can put a ring there. It is difficult, but
Pradeep is talking related to case.
Then, yeah. And after stretching, what I do is I use phenocaine again. I use epitrate or phenocaine. That we will check it. Because of the manipulation, the pupil size also decreases.
Excellent hydrodissection, and this is the soft cataract. Again, okay, sir. Pradeep, here is the question: the stability